Good morning, good afternoon, good evening, wherever you're listening and visualizing our webinar from today. I'm Stephen Grubbs, the Vice President of Clinical Affairs at ASCO, and I want to welcome you to our third weekly ASCO Global webinar series. We are hoping that cancer care experience and lessons can be passed along to everyone during this COVID-19 pandemic to help you in your practice. We have two topics today. The first one will be utilization of telemedicine to meet the demand during the COVID-19 pandemic. And we will hear how a community oncology practice in the United States has been able to increase their ability to communicate with their patients and provide care. Our second topic today will be about burnout and self-care during the COVID-19 pandemic. Next slide. Just as a reminder to everyone, this is a weekly webinar series that occur on Tuesday at 8 a.m. Eastern Time in the United States. The webinars will last anywhere from 45 to 60 minutes, and we're planning to continue these webinars through May 5th with additional weeks as needed. Each one of these webinars is recorded and will be posted on the webinar series page within 24 hours if you would like to either review them or have someone who has not seen the webinar learn from the event. Next slide, please. So before we move on to the program, I just need to let everybody know that the presentations and answers to questions about COVID-19 presented on this webinar are provided by the American Society of Clinical Oncology for voluntary informational use by providers. The information is not intended to substitute for independent professional judgment of the treating provider in the context of treating an individual patient or developing practice policies and procedures. I'm joined today by our Vice President of ASCO International Affairs, Mr. Doug Pyle, who will be ending the program. And we're very, very fortunate today to have our good friend, Dr. Clarissa and Mathias from Brazil act as our moderator today. Next slide. Clarissa, I'll turn it over to you. Thank you.
Good morning, good evening, good afternoon to everybody. It's been great to be involved in this webinar project that ASCO is holding, and we are really happy today to share with you two very practical issues, one about telemedicine and the other about taking care of our staff, our medical oncologists. So to begin, we're going to have Dr. Natalie Dickson. Natalie holds the position of President and Chief Medical Officer for Tennessee Oncology, and you can find her bio in our page in the COVID session at ASCO. And Natalie is going to tell us about utilization of telemedicine to meet the demand during COVID-19 pandemic at a community oncology practice. So welcome, Natalie, and thank you again.
Thank you, Clarissa, and thank you, ASCO, for having me here today. Welcome, everyone. So, Tennessee Oncology is a community medical, gynecology, and radiation oncology practice with 98 physicians and 62 advanced care providers in 33 urban and rural locations across our state. Tennessee Oncology is an ASCO COPE certified practice with a commitment to quality. We have partnered with Sarah Cannon Research Institute to provide clinical trials for patients closer to their homes. And we're participating in a number of value-based payment arrangements, the success of which depends on improved patient outcomes, which requires closer monitoring, effective care coordination, and enhanced support services. But we are challenged by a slowly growing workforce, and may not be able to meet the demands of our increasing patient volumes, especially in our rural areas. And so we looked to telemedicine as an innovative solution back in 2017. We defined telemedicine as the use of medical information exchanged from one site to another via real-time, two-way audiovisual communication to improve patients' health status. Next slide, please. So telemedicine is a very complicated space. We were and are limited by regulation, licensure requirements, and the inability to be reimbursed. In Medicare, the U.S. government's healthcare system for people over 65 and for some younger people with certain disabilities requires that patients are in a healthcare facility and will only pay in rural designated areas, which are not as many as you would expect. The commercial private payers each have its own set of rules. So we therefore looked at pilot projects where payment was less of an issue and settled on providing survivorship visits, clinical trial consent visits, rural hospital consults, and genetic counseling. The rural patients would go to their local clinics and communicate with a centralized team of our nurse practitioners and physicians. And over the years, we have developed standard workflows, policies, and procedures for these initiatives. Next slide, please. We vetted multiple telemedicine vendors who could provide both hardware and software options. And unfortunately, these were too costly at the time, and we had no real way to generate income. So we elected to proceed with an in-house build of hardware and to use our practice's telecommunications network, which is HIPAA compliant. So we created these simple telemedicine carts for the patients to use at their local clinics to communicate with our centralized physicians and nurse practitioners. The carts were assembled with an all-in-one, a 27-inch all-in-one computer mounted on a cart with an 8-hour lithium battery with wireless connection, and they were freely movable around the clinics. The centralized team of providers connected with the patients from their laptops. Next slide, please. So we are now faced with the COVID-19 pandemic, which has forced us all to change the way we live and work. This, of course, includes the delivery of cancer care, and cancer by its nature cannot be put on hold without adverse outcomes. We've had to ensure the continued delivery of high-quality care, and fortunately, there have been unprecedented policy changes at the state and federal level, which has allowed us to expand our telemedicine offerings to meet the acute needs of our patients. Telemedicine allows patients who choose not to travel to continue to have important discussions regarding their diagnosis, their treatment, their symptoms. Being able to take care of patients in this way reduces the number of patients coming into the clinic so that we may maintain safer distancing practices in the office and help to conserve our PPE. It allows us to triage and manage patients with acute symptoms and help keep potentially infected patients out of the clinic and out of the hospital if possible. Next slide, please. So, as regulations were lifted, we immediately expanded our telemedicine offering to follow-up visits, urgent care needs, new patient consults, psychology services, palliative care, and post-bone marrow transplant follow-up. Next slide, please. Our in-house platform is not able to support the current demand, as most of our physicians and nurse practitioners have opted in to provide telemedicine. And we now also have to be able to reach our patients in their homes or place of business. So we quickly sought to identify a more robust platform that was cloud-based and ready to go. And this would allow our patients to use any device, whether a smartphone, tablet, or computer that had a camera and a microphone, had no need for additional downloads, was HIPAA compliant, and was of no cost for our patients. Next slide, please. We had to train our entire staff within a week, and we used web-based training sessions. The classes were tailored to specific groups detailing specific processes. We recorded these training sessions and placed them along with supplemental material on our practice's intranet page for easy review. We implemented the new workflows in 2 waves, and this was very successful as it allowed the smaller group to work out the kinks, the technical and operational kinks, prior to practice-wide use. New slide, please. So we are pleased that we're able to meet our patients' needs in this manner. Our numbers each week continue to rise. Most of the visits have been done by our medical oncologists, but our other specialties are actively participating. Presently, we are averaging about 85 to 90 scheduled telemedicine visits per day across the practice. The feedback from patients and physicians has been very positive. 77% of patients who responded to our survey states that they are highly satisfied or satisfied with the telemedicine visit. Next slide, please. This has not been without challenges. Our IT department had less than 2 weeks to confirm that we had the appropriate infrastructure to administer the telemedicine visits, to ensure that we had adequate number of devices with cameras and mics, and to ensure that we had the internet bandwidth capacity to support all our software applications, including our EMR practice management platform, as well as the telemedicine at all 30 locations. We had known from past care coordination efforts that almost half of our patients did not have smartphones or the technology to be able to benefit from telemedicine. But we learned during this time that even the patients with access to technology were often unable to navigate the technology and sign on to the telemedicine visit. There were several telemedicine visits that had to be abandoned. The off-the-shelf product that we used did not provide the ability for patients to document consent, and so we had to obtain verbal consent. As the product was not integrated with our EMR or practice management system, scheduling was difficult to navigate, and providers found it hard to access medical records during the telemedicine visit. Though Medicare made sweeping changes to reimbursement early, the commercial payers were a little slower and came on board at different times with varying rules. This posed a lot of manual work for our revenue cycle management team. Then there is the uncertainty as to how long this service will be reimbursed. Next slide, please. We have been able to maintain high quality care during this pandemic and see the value of using this service long term. We're now advocating to continue telemedicine at this level after COVID-19. And we're advocating through ASCO and ASH, our specialty societies, our state medical societies, COA, which is the Community Oncology Alliance, and individual payer relationships. We plan to invest in a telemedicine platform with greater functionality, one that will integrate with our EMR or practice management system and patient portal, and to provide real-time tech support for both our patients and providers, have lower broadband requirements, and provide patient reminders, allow our patients to complete paperwork and consent on their own device, and to be able to administer patient surveys consistently. We hope to expand offerings over time to chemotherapy teaching, telepharmacy, as we have a specialty pharmacy, care coordination, and possibly nutrition counseling. We recognize that as we continue to provide remote care and expand our workforce capacity, we may need to reconsider our staffing models and our lease requirements. So thank you for your attention. I will now invite Dr. Nogueira to comment.
Hi, good morning to everyone. Can you listen to me?
Yes.
Thank you, Natalie, for this great presentation. Thank you, Clarissa, Dr. Stephen, and Drew for having me. And before opening to questions, I'd like to share with you some Brazilian data, which probably mirrors other Latin American countries. Now, during the COVID pandemic, telemedicine has become a regulated practice to assist patients in Brazil. Before COVID, telemedicine was only permitted for medical education and so-called teleinterqueries, when a doctor consulted another fellow physician for a second opinion. But the fact is, Brazilian doctors have been informally using telemedicine in both public and private healthcare services, using platforms like WhatsApp, Facebook, Messenger, and FaceTime. It's common for patients in Brazil to send photos of their skin with issues to dermatologists, for example, or test results that in Brazil are sent directly to the patient and not to the physician who requested them. And questions about prescriptions and their doctors will reply with answers. So the innovation with telemedicine during COVID-19 in Brazil is mainly audiovisual. I'd like to pinpoint several positive aspects of implementing telemedicine now in Brazil. Reduction in the volume of office visits, social distancing, limiting the use of PPEs, and better medical access for the population. Brazil is a continental country and has a public health system which is expected to be universal, comprehensive, and equalitarian. Brazil also presents an extremely unequal distribution of medical resources, which now can benefit from telemedicine. And when we think of telemedicine for a low and middle income country like Brazil, we anticipate limited access for technology, and here we have some positive aspects. We have a good telecommunication network, and it's strange compared to the United States that 92% of the Brazilian population has a smartphone or has access to one. However, access to computers is significantly lower. 1/3 of Brazilian homes do not have a computer at all. And another point that raises concern is the security of the available platforms. But I believe from the social perspective, telemedicine has the potential to enhance access to health services in Brazil. We are just scratching the surface, but we should advocate to spread telemedicine during and after COVID-19 in Brazil and in Latin America.
Thank you so much, Angelica, for your comments. And now we're going to go for the questions. And I will start by asking Dr. Dickson, how do you see patients going through the COVID, being away from their physician, especially for the first consultations? How are you handling that? Because here in Brazil, during discussions, we are having trouble, especially with the first consultation where you don't know your physician yet, and you're going to share with your physician, your medical oncologist, the new data regarding your life. So is that the most difficult consultation at this point?
patient consult is the most challenging one. Patients really value that patient-physician relationship that is best fostered face-to-face. But in a time like this, when patients are afraid of visiting healthcare facilities, telemedicine gives the patient some comfort that they can remain safe, minimize their exposure, and yet still be able to have these meaningful discussions and understand what's going on with their new diagnosis and have a treatment plan in place and have their treatment initiated. So while the new patient consult is difficult in many ways, it still is of significant benefit during this time.
Angelica and Doug, and do you have any other questions for Dr. Dickson before we move on to the next topic? Okay, so thank you again, Dr. Dickson, for your wonderful talk. And now we're going to move on to the next topic. And actually, I'm currently the president of the Brazilian Society of Clinical Oncology. And when we took over, we decided to create a network to take care of our medical oncologists. And we were planning to do this along the year, but then we were sort of speed up to do so during the COVID infection. And we developed together with Dr. Angelica and Dr. Moderator a major program to really take care of our physicians who are in such need at this moment now. Dr. Nogueira is an assistant professor of the University of Minas Gerais, and she's also a practicing medical oncologist in the state of Minas Gerais, and now she will take over. Thank you, Angelica.
First of all, I'd like to apologize. I had some issues to connect, and I hope you can see me and listen me well. And on behalf of the Brazilian Society of Medical Oncology, I'd like to thank ASCO for this opportunity to take part in this webinar, in this relevant discussion about burnout and self-care during COVID-19 pandemic. Clarissa, Stephen, and Luke, thank you for having me. Next, please. I'm a Brazilian medical oncologist, and just like the majority of the oncology community, the arrival of May has represented to me the expectation for ASCO annual meeting, always feeling like a new year for oncology practice. Next. And seeing McCormick Place, our sacred temple of knowledge, transformed into a necessary field hospital, was shocking at the first moment. However, a relief soon after. The pandemia's speed is quite impressive, so is our capacity to adapt. Next. Scientists have foreseen 4 waves for this pandemic. The first one, characterized by direct morbidity and mortality of COVID-19. Second, the impact of resource restrictions on urgent non-COVID conditions. Third, the impact of interrupted care on chronic conditions. And here, our oncologic patients will be particularly affected. And fourth, later and long-lasting, marked by economic injury, mental illness, and burnout. But for healthcare workers, the fourth curve seems to peak sooner. Next, please. More than a third of medical staff suffered insomnia during the epidemic in China, and healthcare workers are exhausted, scared, and angry worldwide. Next. And we can pinpoint several contributors to it. First of all, doctors have been suffering chronic burnout. We'll have the opportunity to further discuss it. And adding to that, we are now afraid of getting infected and spreading the infection to others. And not only many doctors are concerned of unpreparedness for ICU tasks, but also worried about the necessity of being relocated. Some have claimed they will simply not come to work and would rather quit medicine altogether. And as everyone, we doctors are concerned about financial constraints to come. And in times when we need to be cared for, we must first care for others. Next. Going back to our chronic burnout, according to the American Burnout and Suicide Report 2020, 42% of oncologists have reported to be burned out, most of whom are Generation X and female. Next. Burnout was classified as severe for more than 45% of the physicians, and more than 15% of the doctors reported to be depressed, and over 20% had suicide thoughts. And all these figures were before the COVID pandemic. Next, okay. Doctors' fear of SARS-CoV contamination, unfortunately, has the weight of history in its favor. Healthcare workers have been disproportionately impacted in past epidemics. According to the WHO, healthcare workers were 30 times more likely to be infected with Ebola than people in the general adult population. Around 20% of people who got SARS during the outbreak in 2002 were medical workers. And sobering figures from Italy and Spain showed that around 9% and 13% respectively of those who died of COVID were health workers in Italy and Spain. Statistically, about 25% of physicians are in the high-risk age category. And the fear of infecting our families have led thousands of healthcare workers to socially isolate themselves, bringing greater disruption in social and familial support. Next. It's reasonable to assume that part of the problem would have been avoidable if health workers had been equipped with sufficient PPEs. It's beyond believable that a request to a team to hold its breath due to the lack of masks was done in UK in early 2020. Next. Before COVID, doctors reported self-isolation, exercising, talking to family and close friends, sleeping, and eating junk food as the 5 most common strategies to cope with burnout. Next. We still don't have any robust data on how to cope with burnout during COVID, but according to a paper recently published on JAMA, the best way to understand what healthcare workers need and what they are most concerned about is to ask. The authors report a discussion with 69 healthcare workers at the beginning of the pandemic, and their insights could be organized into 5 requests to their organization. Hear me, protect me, prepare me, support me, and care for me. To support healthcare workers, medical societies and organizations need to intervene to help protect both their physical and their mental health, considering the need for preventive measures as mindfulness and educational materials, in-the-moment measures, hotline, crisis support, and treatment, telepsychiatry for therapy and medication if needed. Next. The Brazilian Society of Medical Oncology has launched the project to support its members, as cited by Clarissa, Equilíbrio na Travessia, balance throughout the journey. And we have just had the first webinar this morning. We strongly support the need of planning well personal and working lives to cope with this moment. Next. To mitigate burnout, focusing on personal life, plan your week in advance. respect work-life balance, and follow the mnemonic: easy, eat, stick to a healthy diet, build your workout routine, sleep well, take care of yourself, limit social media, stay close to your loved ones, do what you like doing, be grateful. Next. Here we have some suggestions of apps for yoga, meditation, and exercise. Some of them are free. Next. And focusing on work, also plan your week in advance. Do not work 24/7. Take regular breaks. Write your individual mission statement. Enlist your peers for support. Next. And to bring to an end, write down your inspiration. And helping others, just like you have been doing, is one of the strongest inspirations. And here I'd like to share my experience with you. The invitation to do this webinar came shortly after the passing of my sister-in-law, also a doctor, due to COVID. At first, I thought, how would I be able to talk about resilience if I'm crushed inside? However, the opportunity was everything I needed to contribute and pick myself up. I cannot imagine a better formula to increase resilience than understanding the fundamental role of our work in a central crisis of a generation. Please accept this applause. Next. And let this applause transform "We are all exhausted" into "We are all exhausted, but we are okay." Thank you.
Thank you, Angelica, for this great talk. And now we're going to turn it to Natalie to comment on her talk.
Thank you, Angelica. And I just want to say I'm so very sorry for your loss. And, sending out, hopefully, words of comfort from everyone. So we're very sorry to hear about that.
Thank you so much, Natalie.
But thank you for a very nice presentation. Your description of the fears and the emotions and the physical symptoms experienced by healthcare teams around the world are just spot on. That kind of resonates with us here in Tennessee because we're feeling the same. And now we're gearing up to deal with all the pent-up healthcare needs that will come to light as Tennessee prepares to reopen in May. We anticipate a huge surge of new diagnoses and potentially later stages, as elective procedures for screening have been on hold all this time, and patients have been too scared to come to the hospital to report new symptoms. So thank you for sharing the recommendations and resources on how to mitigate burnout during this time. I mean, we can't control the situation, but we can control our response and, our attitude and our behavior. And so I agree that we must take care of ourselves and find a way to recharge. I like that easy mnemonic, and I'm going to try to remember all these points. And as a Generation X woman, I take this to heart.
I'm in the same group.
So, we can't forget our families. I mean, they need us as much as our patients and our practices. And as leaders, it's important that we keep informed and we communicate with our teams regularly, be empathetic, and listen to their needs. As you so clearly stated, a significant number of oncology providers struggle with burnout even before COVID. As a practice, we tried to address this in various ways over the years. But I can tell you that this COVID pandemic has given our efforts a boost, kind of shot in the arm. you had a webinar today, and like our psychologists, we have 3 on staff. They created a webinar entitled Being Resilient in Tough Times. It was an amazing presentation. There were 4 live sessions that were provided, and the response was tremendous. We had over 450 participants, much more than we anticipated. So we could see the need for this. As a result, our HR department has reminded folks of our EAP benefits. This is Employee Assistance Program benefits for our staff and their families, and several folks have taken advantage of this. And we have also embarked on a new initiative. And I believe this is taken from a Johns Hopkins program where we're training a number of people across our practice to be able to provide on-demand peer support. Our clinics are scattered all across the state, and some of our team members feel somewhat isolated. And just to say, your conclusion was very moving. It portrays the self-sacrifice and the generosity of our healthcare providers everywhere. And we need to remain courageous. We need to remember that we're part of a very strong, resourceful global oncology and medical community. So thanks again for your talk. Thank you.
Thank you, Natalie.
Thank you, Natalie, and thank you, Angelica. And so, Angelica, what do you offer next in terms of the physicians who work with you? Those who have to stay home because they're either infected or because they are part of a risk group. Are you offering any kind of constant checks? I think this is a good thing to do, check in on people and really try whenever, and maybe like giving them some options to do things at home that they can help the staff that has to be there on the front line.
I think all of us are learning through this process, and it's time to hear the necessities are different, and that's the main conclusion of the JAMA paper, that people want to be heard, and probably that's why we are seeing so many people connecting to our webinar. We want to stay together. We want to talk, to be listened, and to listen from you. And also at home, I think that the same that we are doing at work, we should do in our homes, to be more tolerant, listen to, and to be grateful for our health, and expect that it will pass.
Yeah, I think that's the main learning point from all this pandemic, that has really put all the countries at the same level in terms of fear, in terms of compassion, in terms of problems. And I'm really grateful for ASCO for being such an international organization and really taking care of all of us. These webinars that have been really thought and planned very well have really gotten their objective. And now I would like to turn to Doug Pyle. It has been a great pleasure to work with Doug for so many years, and he's the head of this project. And thank you, Doug, for doing so.
Well, thank you, Clarissa, for those kind words. And so I'm Doug Pyle. I'm the Vice President for International Affairs for ASCO. Just like to say thank you to our panelists, Dr. Dickson and Dr. Nogueira, for your insightful comments, tremendously helpful, in some ways quite poignant comments, sharing your thoughts from your own experience sure will be very helpful to our panelists today. I'd like to thank Clarissa and Steve for guiding today's call and for moderating so well. I'd like to thank all of you for joining us today from wherever you are. As Clarissa said, we are a global community and we all need to support each other. Thank you for joining us. I hope you will join us on May 5th for the next webinar. And as Steve said at the beginning, these are being recorded and recordings will be shared on the ASCO website. In addition, if any of you are interested in a certificate of attendance, you can send an email to us. If the next slide could be shown, the email address is shown there. I'm sorry, the email is international@asco.org. Is also available on the website. Once again, thank you, Dr. Dickson and Dr. Nogueira, for sharing your insights today, taking the time to join us, and all of you for joining us. And please take care and stay safe. And thanks again.